The following podcast is part of a certified educational activity titled Staying Current on Immunotherapy for HNSCC, Conversations on Clinical Collaboration and Treatment Selection. Access the entire activity and complete the post-test at peerview.com/BGV860. Downloadable slides and practice aids are also available.
Hello, I'm Professor Kevin Harrington and I work at the Royal Marsden Hospital in London. Welcome to Staying Current on Immunotherapy for Head and Neck Squamous Cell Carcinoma. I'm delighted to welcome my colleague and friend, Professor Christophe Letourneau from the Institut Gustave Roussy in Paris, France, to this conversation. Great to see you, Christophe.
Great to see you, Kevin.
So today we will discuss some of the recent developments in immunotherapy as neoadjuvant and adjuvant treatment for head and neck cancer. But we will also review its long-standing role in the setting of recurrent and/or metastatic disease. During the program, we will also provide case examples to illustrate how multiple disciplines, including pathology and surgery, contribute to the use of immunotherapy in patients with head and neck cancer. We've also collected some of the material in this activity, including regulatory and guideline updates, and this is made available as a resource, which you may want to download now. So, without any further ado, let's get started. So, Christophe, first of all, we've seen unprecedented changes in the use of immunotherapy over the last years. It's really interesting to see how we've been able to move from the relapsed metastatic setting into the treatment of patients who are receiving curative intent treatment. It's really been a time of change for us, hasn't it?
Oh yeah, a big change. And I mean, when I started my studies in head and neck oncology, we were not curing patients in the recurrent metastatic setting, which we are now doing with immunotherapy. So this is a great time.
Yeah, it's been a remarkable time. And of course, we have much still to do. And this is something that we're going to discuss as we build upon the evidence that we've already generated. So I'm going to just give some first introductory comments before we get into discussing some real-life clinical cases. So our goals for today during this presentation, we're going to look at biomarker-guided use of immunotherapy and how it remains a standard of care approach to the use of immunotherapy in patients with relapsed and/or metastatic head and neck cancer. We're going to review how the evidence now supports the use of immunotherapy in locally advanced head and neck squamous cell carcinoma, including use as neoadjuvant and also as adjuvant therapies. We're going to look at how integrating perioperative immunotherapy into the treatment paradigm is going to be done in collaboration with multiple members of the MDT, notably an interplay between oncologists, surgeons, and pathologists, and other wider members of the team. So let's first look at how we are using immunotherapy, and I'd like to review the approvals for PD-1 inhibitors in the setting of relapsed metastatic disease, and I'm going to contrast and compare the approvals that are in place both in the European Medicines Agency region and also in the US through the FDA. Now, when we look at the drug pembrolizumab, EMA approvals for this in the relapsed metastatic setting are for those patients with a CPS greater than or equal to 1, where we have approvals for both monotherapy pembrolizumab or use of the drug in combination with platinum and 5-FU chemotherapy. In the FDA region, in the first-line relapsed metastatic setting, pembrolizumab plus platinum and 5-FU is approved for all comers irrespective of CPS value, and single-agent pembrolizumab is available for those with a CPS greater than or equal to 1. When we look at the use of treatment in the post-platinum relapsed metastatic setting, monotherapy availability of pembrolizumab is in place both in the EMA and in the FDA regions. Now, in terms of perioperative treatment in locally advanced head and neck squamous cell carcinoma, building on the data from the Keynote 689 study, we have similar approvals, and this is based upon a CPS greater than or equal to 1. It's important to recognize that for pembrolizumab, the subcutaneous formulation is approved across all adult indications, and that includes head and neck squamous cell carcinoma, of course. Now, when we also look at the approvals for nivolumab as a PD-1 inhibitor in this setting, we can see that in the relapsed metastatic setting, post-platinum, both in the FDA and in the EMA regions, monotherapy nivolumab is approved, and again, this is available as a subcutaneous formulation. Now, when we think about the ESMO guidelines, they give us very clear indications of how to use these medications. So for patients who have received no platinum-based chemotherapy during the last 6 months and who are PD-L1 or PD-1 inhibitor naive and who have got PD-1 positive tumors, those patients can receive either pembrolizumab monotherapy or pembrolizumab plus platinum and 5-FU. Other options include regimens such as the extreme regimen, and also for patients who are unfit for platinum or have contraindications for immunotherapy, they can be treated with other agents, including methotrexate or taxane or cetuximab-based therapy. When we look at patients who have had no platinum-based chemotherapy during the last 6 months and a PD-L1 assessment has not been carried out, those patients can indeed be treated with a combination of pembrolizumab plus chemotherapy, and other options again include the use of the extreme regimen and those other single-agent therapies that I discussed, methotrexate, taxane, or cetuximab, for those patients who are unfit for platinum and for whom there is a contraindication for immunotherapy. For patients who have not received platinum-based chemotherapy during the last 6 months, but whose tumors are PD-L1 negative, those patients are recommended as standard to receive a regimen containing platinum, 5-FU, and cetuximab. Now, other options do include the use of pembrolizumab chemotherapy-containing regimens, the TPEX regimen, or indeed, again, those same 3 single-agent cytotoxics, methotrexate, taxane, or cetuximab. When we look at patients who have been pre-treated with platinum-based chemotherapy within the last 6 months and who are immunotherapy naive, those patients may be treated with single-agent nivolumab or pembrolizumab therapy, and again, they could receive taxane, methotrexate, or cetuximab therapy. And finally, if we look at that group of patients who've been pre-treated with platinum within the last 6 months and have also had prior immunotherapy, their options are more limited and relate to the use of taxanes, methotrexate, or indeed cetuximab. Now, the use of CPS testing is important prior to treatment, and we should do this using a selected, validated assay. So this is often done to inform systemic treatment selection, and CPS testing is certainly recommended when considering first-line pembrolizumab-based regimens. The test should be a validated, quality-assured PD-L1 immunohistochemistry assay. The CPS value is based around PD-L1 positive tumor cells plus lymphocytes plus macrophages divided by the total number of tumor cells and multiplied by 100. So therefore, it incorporates an element both of tumor staining and the tumor microenvironmental staining for PD-L1 positivity. Now, we know that there is a strong indication, as I've discussed, for both single-agent pembrolizumab and pembrolizumab chemotherapy regimens in the treatment of patients with relapsed and or metastatic head and neck cancer. And those data are based upon the KEYNOTE-048 data. We know that for single-agent pembrolizumab, that for the CPS greater than or equal to 20 group, for the CPS greater than or equal to 1 group, there is a statistically significant and clinically meaningful improvement in outcome for patients who receive pembrolizumab as opposed to the extreme regimen in that study, and that is in terms of overall survival data. Now, again, for the total population, the pembrolizumab therapy was superior to the extreme regimen, but this did not lead to a broad approval and certainly not within the EMA region. So, against that background, Christoph, I'd like to bring you in here and I'd like to discuss a case with you, if I may. So Robert is a 67-year-old man who initially presented with a T4A-N1 loco-regionally advanced laryngeal carcinoma. He was treated initially with surgery and chemoradiation in the post-operative setting, and regrettably has developed a loco-regional recurrence 10 months after the completion of chemoradiation. So maybe I could start, first of all, by asking, should PD-L1 testing be the next step before deciding on treatment, or are you ready to start treatment already?
Now, I think it's very important to get the PD-L1 testing result because, as you showed, Kevin, with the Keynote 48, pembrolizumab alone or pembrolizumab plus chemo does better than the extreme regimen in patients who are PD-L1 positive. So it's really important to get that information to know whether we would treat this patient with immunotherapy or not.
And would you do this on the sample of the tumor that is there in the archival material, or would you insist upon a fresh biopsy at this point?
Yeah, I think it would be better to get the result based on a fresh biopsy from the recurrent setting. Now, if we don't have that, I'm happy also to base my decision based on archival tissue.
Okay, so let's imagine that we've actually taken that fresh biopsy and you've got the result back. So using the 22C3 assay, we've got a CPS value of 25. The patient is otherwise reasonably well, has no major comorbidities. Based upon those relatively limited clinical data, what are you thinking about as possible next steps that you would recommend?
I mean, a CPS score of 25 is quite high. But even though if the patient had a CPS more than 1, I would actually treat this patient with pembrolizumab alone. Why? Because what we think is that the only patients who are cured in the recurrent and metastatic setting are the ones that respond to immunotherapy. So if we can avoid chemotherapy, I think it's better for the patient. And here, it has elapsed 10 months between the initial treatment and the relapse. And I think it's okay to start with pembrolizumab alone. Then we need to watch the patient quite carefully to see whether there is no progression, and maybe to add chemotherapy to immunotherapy or to switch to chemotherapy if this was the case. What do you think, Terry?
Yeah, so I have to say, Christoph, I agree with you. So long as the patient is generally clinically stable, doesn't have a high burden of symptoms or indeed a high burden of disease, then I think a chemotherapy-free approach is very sensible in the first instance. But let me turn the tables a little bit. Let me maybe switch the case around. Let's imagine the patient presents with peristomal recurrence of his laryngeal carcinoma. Airway is slightly threatened. The patient is symptomatic with pain. Would you change your view if the CPS was lower? Let's imagine actually the CPS now, rather than being 25, it's 8. What are you going to do now in a patient with peristomal symptomatic recurrence and CPS 8? Are you still going to stick with your single agent pembrolizumab?
I mean, the likelihood to respond with a CPS of 8 is less than with a CPS of 25 that we know from the data. Here, the patient is symptomatic and there is a risk of obstruction of the airways. So I would feel more comfortable to start with chemotherapy and immunotherapy. What would you do, Kevin?
Yeah, I agree entirely. I mean, I deliberately, I think, posed the question in a sense where this is the sort of patient where one is worried that you could lose control of the disease by starting with pembrolizumab alone. So I think some chemotherapy as a combination regimen makes a huge amount of sense to me there. So now I'd like us to move on and think about the mechanistic rationale for using neoadjuvant immunotherapy. So this is in the setting of patients where we're treating them with a curative intent. And I'd like to consider this from the recent data that we've seen in the either preoperative, postoperative, if we like, the perioperative setting. And here we're looking to exploit really two mechanistic approaches that immunotherapy brings. So the first, of course, is that the immunotherapy can unleash the activity of pre-existing immune cells, leading to anti-tumor activity within the previously untreated disease, and of course could downstage the disease before, for instance, a surgical procedure. But I think what many people are thinking about now is the use of immunotherapy as an adjuvant treatment, essentially immunizing the patient in situ to their disease, where the antigen from the tumor is present when the patient initially receives treatment in the neoadjuvant phase. And those cells, those immune cells that have been triggered to react against the tumor, remain present in the post-surgical adjuvant phase, including during radiation. Now, of course, in the Keynote 689 phase 3 study of pembrolizumab in patients with stage 3 to 4A resectable locally advanced head and neck cancer, this is precisely what we addressed. So that group of patients with locally advanced disease, now this did include oropharyngeal HPV negative and HPV positive patients based upon P16 staining. Patients were randomized on a 1-to-1 basis between either neoadjuvant pembrolizumab for 2 cycles at a dose of 200 milligrams intravenously every 3 weeks, or proceeding directly to surgery. Both groups of patients underwent surgery after pathological evaluation and assessment of key tumor characteristics, including resection margin and presence of extranodal extension within lymph nodes. They were assigned into low or high risk groupings and recommended to receive either radiotherapy as an adjuvant treatment or chemoradiotherapy as an adjuvant treatment. And the decision around chemoradiation was based around a positive margin and extranodal extension in the lymph node. Those patients who had initially been treated with pembrolizumab in the neoadjuvant phase continued with that treatment during the radiation and for a whole year after the completion of the radiation or chemoradiation. Now, the outcome of this study, with the primary endpoint being in the CPS greater than or equal to 10 population, showed a statistically significant and clinically meaningful improvement in event-free survival when the pembrolizumab arm was compared with the standard of care arm. Now, in the statistical analysis plan that allowed us then to subsequently test in the CPS greater than or equal to 1 population, where that significant difference persisted, and indeed also in the total population, where again there was a benefit in favor of pembrolizumab. Now, importantly, we also saw that this benefit persisted when we looked at both the low-risk patients, so those who received adjuvant radiation as opposed to chemoradiation, and the high-risk patients, those who would have been allocated to the treatment with chemoradiation as opposed to radiation. So in both groups of patients, pembrolizumab performed better than the standard of care alone arm. There were other benefits that we saw to accrue to these patients, notably patients who received pembrolizumab perioperatively received a lower dose of radiation, and that was based upon the pathological findings in the tumor resected specimen. So the median dose delivered in the pembrolizumab arm was only 60 gray, whereas that in the standard of care arm was 66 gray. We also saw that fewer patients in the pembrolizumab arm required treatment with concomitant platinum, so potentially reducing the burden of toxicity. And when we look at the toxicity grading, we can see that there were changes in favor of the patients receiving pembrolizumab plus standard of care versus standard of care. But of course, we did see a burden of immune-related toxicity, and we can see that certainly any grade immune toxicity was significantly more prevalent in patients receiving pembrolizumab, as one might expect, and this was also true at grade 3 or greater. So, Christoph, I've now reviewed those data from Keynote 048, which of course speak about the perioperative opportunity, but I'm very aware of the fact that there are also data relating to the use of adjuvant immunotherapy in this context. Maybe I could ask you to review those data.
Yeah, thanks, Kevin. Indeed, the only trial, a phase 3 trial that was reported to date, has been the nivolumab trial led by the Gortec that evaluated the addition of nivolumab to surgery followed by chemoradiation in patients with high-risk locally advanced head and neck squamous cell carcinoma. So these patients, before randomization, had to have undergone surgery with a complete surgical resection and to have a pathological stage 3 or 4 disease. These patients had to have as well high-risk pathological features that we will review in the next slide. So patients here were randomized between chemoradiation with high-dose cisplatin as a standard arm and nivolumab 1 dose followed by chemoradiation in combination with nivolumab and followed by 6 injections of nivolumab. So as you can see here in the patient characteristics, so most of patients here had a pathological stage 4 disease. And what you can see is that 90% of these patients had high-risk features, including extracapsular fraction or positive margins. 10% of patients had multiple perineural invasion or more than 4 invaded lymph nodes. So if we look at the primary endpoint, that was disease-free survival, we saw here a benefit in terms of disease-free survival in patients who received nivolumab in the adjuvant setting with a hazard ratio of 0.76 and a p-value of 0.034. It's important to see that similarly to what we have seen in the Keynote 689, patients had in the experimental arm some adverse events related to nivolumab that were expected, but the toxicities related to chemoradiation were the same in both arms. So let's move now to some cases for patients who have locally advanced head and neck squamous cell carcinoma.
So again, Christophe, I have a patient now. We have a French patient, which is in keeping with your practice. So Bertrand is a 59-year-old man with a little over 3 centimeter P16 negative T2N1 M0 stage 3 oropharyngeal squamous cell carcinoma. So he's got a single ipsilateral node without extranodal extension by imaging, presenting with dysphagia and otalgia. It's got a good performance status, and the CPS value is 15 at this point. So, first of all, this patient presented with oropharyngeal squamous cell carcinoma. Do you think this patient would be a good candidate for a perioperative immunotherapy approach if you accept the fact that you're going to treat this patient surgically in the first instance?
Yeah, I think this patient is a good candidate for perioperative immunotherapy. I mean, this patient is not high risk. It's a T2N1. So that patient, he's probably not a high-risk patient because he has a T2N1 disease, a stage 3 disease. Now, Kevin, you showed the results presented at ASTRO, showing that not only high-risk patients benefit from perioperative immunotherapy, but also low-risk patients. So I definitely think that this patient, given he has a CPS exceeding 1, is a good candidate for perioperative immunotherapy. Would you agree with that?
So, I mean, I think we could discuss, and I'm sure each of us would discuss in our own respective MDT meetings, whether or not you would treat a patient like this with definitive chemoradiation, for instance. But if we accept the fact that this patient is going to receive a surgical approach with the aim of achieving a complete resection of the disease, it makes great sense to me to use an immunotherapy approach in the perioperative setting here. We've seen the data from Keynote 689 that have shown us that we have a greater chance of giving a lower dose of adjuvant radiation, which may reduce long-term toxicity. There is a good chance that this patient may avoid the need for adjuvant cisplatin alongside that radiation therapy, especially if they have a pathological response to that perioperative treatment. And we know from the clinical study that for the patients who had high CPS values, that those patients were potentially likely to have a good response. And we saw major pathological responses of up to 13%. And a major pathological response, of course, indicating less than 10% of viable tumor in the resected specimen. So I think there would be a good case to be made here that this patient would be a good candidate for a perioperative immunotherapy approach if we're going to treat this patient with surgical intent. So maybe I could ask you, because we've seen the CPS is 15, maybe I could ask you, Christoph, if you didn't have that CPS information when you were first looking at this patient, would you be looking to do a PD-L1 test straight away? And what logistical issues do you see in having to do that? Because that's a bit of a change in our practice, isn't it?
Yeah, I think it's important to get the PD-L1 results, but it can be a challenge indeed, Kevin, because in some cases, the endoscopy was performed in another center, and then we need to get the slides to evaluate PD-L1 if it has not been done in the other center. I think it's really important to get organized so that we do not delay the treatment. That's probably the most important thing. What we have decided to do at Gustave Roussy is to organize everything as if the patient would receive perioperative immunotherapy, hoping that we get the results of PD-L1 just in time, knowing that most of patients actually will be PD-L1 positive. So that's our strategy. But in any case, we would not like to delay the treatment.
So in light of that discussion, I'd like us now just to think a little bit about the workflow around perioperative immunotherapy. And here you can see a suggested timeline that we can think about. So if we start at the initial diagnosis and workup, key, of course, is a biopsy of the lesion to make the diagnosis and to assist with staging and to review in the MDT. Now, of course, if the decision there is for a resection of the tumor, it's going to be absolutely critical at that point, as Christoph has discussed, that we order that PD-L1 CPS value. Now, it may be necessary in patients coming from outside centers being referred into, for instance, a central MDT, that we might need to rebiopsy that lesion in order to expedite the measurement of the CPS. And of course, we will want to know the P16 value for patients with oropharyngeal carcinoma. Now, if we imagine that on the basis of those data, we confirm eligibility for an approach involving perioperative pembrolizumab, so neoadjuvant treatment to start on a 3-weekly schedule, and that would be based around findings such as a PD-L1 CPS greater than or equal to 1, and a staging that put the patient in a stage 3-4 category for HPV negative disease, or stage 3 category for HPV positive disease. Then we would look to schedule starting cycle 1 treatment of pembrolizumab as a 200 milligram intravenous injection. Of course, we could also now consider using the subcutaneous formulation. Now, part of that process has to be a coordination with the surgeon who is going to be then planning the patient, putting the patient in the diary for a subsequent surgical approach after they've received the second cycle. So that engagement with the surgeon is critical and should certainly happen before cycle 2 pembrolizumab is delivered, preferably even earlier than that. Now, subsequently, the patient will go to definitive surgery having received the neoadjuvant dosing with pembrolizumab on 2 occasions. And then we once again return to the pathologist as giving us critical information as the third step in this process. Now, the pathologist will give us the details around the tumor, and in particular, we want to know about the risk status of that tumor in the postoperative setting. And that is based around the margins and the presence or absence of extranodal extension. And that dictates the need for either adjuvant chemoradiation if high-risk features are present, or adjuvant radiation if lower-risk features are present. Of course, we want to know about the staging of the disease, and we will also want to know about whether or not there has been a major pathological response or indeed a minor pathological response to immunotherapy. Based around those data, the patient will subsequently proceed to postoperative radiation or chemoradiation with pembrolizumab. Ideally, radiotherapy should start within 6 weeks of a surgical procedure, and we know that that's associated historically with improved loco-regional control and patient outcomes. The patient will continue with 3 weekly pembrolizumab during this phase of radiation or chemoradiation. And finally, having come out of that phase of adjuvant radiation or chemoradiation, the patient proceeds to maintenance pembrolizumab for a total of about 1 year of total exposure using a 3-weekly schedule. Indeed, we do also have potentially the opportunity to use 6-weekly schedules, although that was not part of the Keynote 689 design. So, if we return to our patient Bertrand, and we look at his case, again, the same scenario, Christophe, but I'd now like to pose the question instead. Rather than Keynote 689, would you have considered this patient as being a candidate for the Nivo post-op approach instead?
So we need to get the pathology report of that patient following surgery to see whether the patient has a high-risk features, including extracapsular extension, which we cannot see on the imaging before surgery, but we never know. Or this patient has invaded margins, which is very unlikely because the patient has a T2 and 1, but we never know. But at the end, I think it's very unlikely that this patient would be a good candidate for Nivo post-op because it is very unlikely that this patient has high-risk features. But definitely, we should have the pathology report before taking any decision. What would you do, Kevin?
Yeah, I think this is a really important question, isn't it? Because although many people may see Keynote 689 and Nivo post-op as being rather similar studies, they were actually in very different patient populations. And I think the stage of disease that this gentleman presents with is far more in keeping with the sort of patient who is likely to have been a good candidate for Keynote 689, whereas Nivo post-op was conducted in a group of patients really with, I think, more aggressive, higher stage disease. And of course, that was based around, an entry into the study was based around a pathological evaluation of the tumor having undergone surgery. So I think this is a different approach. I agree with you. But if we think about the use of neoadjuvant or adjuvant immunotherapy, slightly different, or maybe perioperative versus adjuvant immunotherapy, there are, of course, overlapping toxicities that we have to think about giving immunotherapy to this group of patients. What do you think are the key things that we need to bear in mind and to address, Christophe?
I mean, I have to say that it's not a big deal to check the toxicities of these patients, and especially whether they're overlapping or not. So if we go into the details, and let's take as an example dermatitis. The dermatitis induced by radiation is localized, whereas patients can get rashes related to immunotherapy that are more like a rash and diffuse. It's quite different, and the timing of the occurrence of dermatitis with radiation is quite clear. Head and neck edema is very uncommon with immunotherapy. Hypothyroidism is quite common with radiation, but also with immunotherapy, starting usually with hyperthyroidism followed by hypo. But it can be difficult to differentiate whether the hypothyroidism is related to radiation or immunotherapy. But at the end, it doesn't make a big difference because the treatment is exactly the same.
So it's been a pleasure speaking with you, Christophe. And so I'd like now just to bring this to a close and maybe review some conclusions that we can draw around the use of modern immunotherapy and the choices that we have to make in head and neck squamous carcinoma. So we know that immunotherapy, with or without chemotherapy, remains a standard of care management treatment for patients with relapsed and/or metastatic head and neck cancer. More recently, in the setting of locally advanced head and neck squamous cell carcinoma, the Keynote 689 study has established a role as a perioperative standard of care in resectable locally advanced head and neck squamous cell carcinoma for pembrolizumab, and this has been approved by the EMA and the FDA. We have also seen that the NIVO post-op study has shown us that adjuvant anti-PD-1 therapy added to chemoradiation can improve outcomes, particularly in those patients with high-risk features. We look forward to the development of future immune therapy-based modalities, which are being planned and indeed being tested. So, Christophe, it's been a great pleasure discussing things with you. And to the audience, I thank you for your attention.
Thank you, Kevin, for this nice discussion and for your attention. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Merck Sharp Dohme LLC, a subsidiary of Merck Co. Incorporated. To access all materials for this activity, visit peerview.com/BGV860.